So thanks so much for, number one, having this conference. I think this is a great conference. This is the fourth time we've had a conference like this in Austin, and I think every time there have been more folks here, and I think every time we have one of these, I get so much great feedback about how it really is, it allows people to understand myeloma a lot better. And so I think that one of the things I always encourage is for patients, their family, and people who are with them to sort of ask as many questions as you want, because I know when we go and meet with you in the clinic, there's a limited amount of time. So you can, feel free to ask any questions. There's plenty of time today to do that. So I've been asked to talk about sort of how do you think about myeloma as a treatment process over time, because it's not as if you get diagnosed and then there's one treatment you do and then you don't have to worry about it ever again. It's a sort of a long journey. So one way to think about it is just thinking about like, where are we in terms of how we've progressed in myeloma. So up at the top, there's a curve here. And so as the previous speaker had provided, these are survival curves where, you start out with 100% of people, and then over time, this is a survival curve. So this represents the number of patients remaining. And so this is separated out by decade. And so you can see every decade going from the blue all the way up to the top is that patients live longer with each decade. So that what that tells us is we think we're making progress in terms of improving the survival of patients. And so I often tell patients or people that, when I started taking care of myeloma patients, it was in the sort of mid-90s, and when patients got diagnosed with myeloma, we would sit them down and say, this is an incurable disease, and on average, people live 2 to 3 years. So it's a very different conversation that we have with people now, right? And I think that it's really, part of it is the development of all these drugs. So you can see at the bottom, there's a timeline of all the drugs that have been approved by the FDA. But the other part of it to remember is that it's really like patients going on to trials, which allows these drugs to be approved. And so I think patients have contributed to developing these approaches, and it's been a way of, I think, giving back to the community, as people have told me in the past. So we've improved with time, and I think that, that coincides with us developing better therapies. And so one question always is so if we have all of these therapies now, so how do we now think about using them, sequencing them, combining them, et cetera? So the dilemma we have right now is we have a lot of different drugs available, right? Obviously, we're not going to take all of those drugs and give them to one person at one time. We have to sequence them out. And so we have different classes of drugs. And so the first one is cytotoxic chemotherapy. Those are things like melphalan and high-dose therapy. There are things which are targeted therapies, which have been the greatest development early on. Those are like IMiDs and proteasome inhibitors. There's been more antibody-based drugs that's been throughout cancer, including myeloma. And now it's really the immunotherapies that have been driving sort of a lot of progress over time. So if we have all these drugs, right, so the question is that how do we sort of use them? And the goals for us just in general are, how do we maximize their benefit, right? So what we want to do is we want to have people live the longest and maintain the quality of life that they would like. So we want to have people live the longest, but have them suffer as little as possible from the side effects. So it's really a balancing act. So there's this, this idea of personalized medicine, which is not universal, which is universal. It's not just myeloma, which is like it actually is not a one size fits all. So for each individual patient, it may be a different set of things that we talk about or recommend. And then our challenge is that if we have all these drugs, can we determine what are the best therapies to use at the best time for an individual patient, right? So can we figure out what's going to work best for a certain patient? So the way to think about it is to think about something called risk, right? So you can have patients who are in this prognostic category, which is high or low. So the way we think about high-risk patients are that they have more aggressive disease. It will grow faster. People will tend to be sicker from that disease. Patients with more aggressive disease tend to live a shorter amount of time. So really the goal of the treatment here is to try to break that cycle of if you have a disease in which is aggressive, your lifespan is shortened, then can we actually move that away from that natural history and make you live longer? And to do that, we want to match the intensity of our treatment with the aggressiveness of the disease. And so in general, patients with high-risk disease, we focus on doing more early on, and we're more aggressive with our therapy. Those with lower risk disease, we would say, look, the disease is growing slower. We think that you're going to have a lot more time. So what we want to do is we don't want to burn through therapies that are going to produce a lot of toxicities that you're going to have to live with for the rest of your life. We want to maintain your quality of life as much as possible, so we may use less aggressive approaches. So the first attempts of doing this are staging. And so every cancer that we treat has a stage. And so if you think about things like breast cancer, lung cancer, colon cancer, there's stage 1, 2, 3, and 4 in general. In solid tumors, it ends up being that your stage is related to where the cancer is located. So in breast cancer, it's stage 1 is it's localized to the breast. Stage 2 and 3 might be, or stage 3 might be it goes to the lymph nodes, and stage 4 it sort of goes through your body. So each one of those stages, it's sort of the extent of disease spread. In myeloma, since it's a disease of the blood goes everywhere, so it's everywhere by definition. So you can't localize it in that way. So there have been attempts to try to divide patients up into different groups to identify those patients with aggressive disease versus those with not as aggressive disease by stage. So the first way of sort of doing this in a systematic way was something called the International Staging System. This was in 2005, and it really is 2 different labs that allowed you to stage someone. So one is something called the beta-2 microglobulin, and the other one is serum albumin. Neither of these 2 things are really super specific to myeloma. So it's a little bit weird that these are the 2 things that are there. And so they divided patients into 3 groups. So it's based upon these 2 lab results. And so you can see that there are sort of 3 different curves here. And with each, So with each group, there's a different survival curve, and you can sort of parse people out. So, and they would have a variable amount of time, variable overall survival. So that was the first attempt at doing this. So can you find patients who are stage 3, have more aggressive disease versus stage 1? And you might think about treating them a little bit differently. But if you see here, there's not that much of a difference between the separation of these curves. And so one dilemma is this good enough to sort of say one person had to go to one therapy versus another? So the one thing about risk assessment is that when we talk to people about risk, I think it's not a intuitively easy thing to kind of grasp. And so when we think about, when we talk to someone about high-risk disease or low-risk disease, when we talk to each other about this, it's really we're thinking about what is the probability of having something happen, right? So those might be things like what is the chance that you get a chemotherapy and it makes your myeloma go down? How does it affect the time if you go into remission before you relapse? And then the other is that how long overall does one live from when you get diagnosed to when you pass away from the disease? So the one thing about risk is that, and I know there are statisticians who I'm sure I'm butchering this and they'll be appalled by this, but really risk is statistical, right? So it's not, and what I mean by that is the probability of an outcome. So if you're at high risk, there's a higher chance that something is going to happen versus if you have low risk. So it's kind of like if you are watching TV and someone says, well, there's a 20% risk of rain, right? I'm like, well, what does that mean? Does that mean that 20% of the day it's going to be raining? Is it that there's a 1 in 5 chance that it'll rain at all? Like, well, what does that sort of mean? So that's sort of a risk. It's a probability, it's a chance of something happening. It doesn't say that it's gonna happen. So if you're at high risk, right, it means that you have a higher chance that, you know, these issues will come up, but it doesn't guarantee that that's gonna happen. If you're at a low risk, it means that we think you're gonna have more indolent disease, but there are outliers to that. So the other is that risk is something that can change over time. We're always thinking about what other things can we put into these models to calculate risk. And then part of the risk is also depends on what treatments are available, right? So if you add in a treatment, it may change sort of the outcomes of people as a group. Just like as we add in more drugs, people are living longer and longer and longer with myeloma. So risk factors are typically you need multiple of them to figure things out. Each factor might contribute to your risk differently. The other is that there are prognostic factors that people talk about. Those are things that are associated with risk, and they're predictive factors. And I think that predictive factors are more things like if you have X and you treat it with Y, that Z will happen. So it's really more associated with, can we tell who's going to respond to a drug or not? It's not sort of these sort of larger factors. And so I think that, though, if you can figure out risk categories well, then you can improve how we approach patients. So one of the things about cancer is that it is a genetic, they're all genetic diseases, right? So you have mutations in genes, and those drive the development of cancer. And so the way that we assess genetic changes is primarily through FISH testing now. So FISH testing is you get these little tiny probes, and what they do is they can actually bind to a different chromosome. And so what you can do is you can sort of see whether or not you have, so we're supposed to have two copies of every chromosome. So if you have a, let's say, something where you have, say like this, you have two chromosomes, and now if they break apart and come back together, then the probes, instead of being scattered about, are going to be next to one another. So that tells you that mutations happen. If you now go through and you like have two copies, and now you only see one signal, it means one of them is missing, right? So that's the way that we can gauge chromosomal dynamics in these patients. So this is a study that is commonly done patients as they're diagnosed. So through this, we can divide up patients into different cytogenetic or chromosomal change categories. And so in the beginning, what people think are there these founder sort of mutations. And so you can either have two large groups. So one is hyperdiploidy, where you have just extra chromosomes. You have your chromosomes and you have extra ones on top of that. Or you have translocations where you have two chromosomes, they're out here, and then they sort of break apart and they join together back in an abnormal way. So there are either extra ones or ones where they're broken and joined back. And then you could have other ones that are, you can lose part of a chromosome or you can gain part of a chromosome. And so those are also things that happen at that level. So if you have these genetic changes that we identify, and we now take our staging system that was developed in 2005, and now we add the genetics onto them, can they make it better? So this was done about a decade later, and it's the revised international staging system. And so you have stage 1, 2, and 3, right? And basically you use the original stages, and then what you do is you add in some chromosomal abnormalities. And so if you have additional chromosomal abnormalities that are these high-risk ones, it now drives you into the third stage. And then if you don't, you can still remain in one. So we now are starting to separate out the curves a little bit more, right? So these are patients at a low risk or at a lower stage. These are at a higher risk. And so this was another way where we're now refining what we had in 2005 to now what we have in 2015, we developed in 2015. So this is sort of was the standard by which we identified patients at high risk. Part of this issue here is that if you look at the numbers that they used to develop these models, the second stage, which is like you kind of anything, it's like the kitchen sink stage where it doesn't fit in 1 and 3, so everything's in 2. that has the vast majority of patients. And so everyone gets sort of dumped into this one stage. You can't separate those patients out. So one of the things that was important was to sort of figure out, well, who are the patients at high risk? Because those are patients who we need to think about doing more things, research-wise with, because those are the patients at highest risk. So this is just sort of hot off the presses. This is how the International Myeloma Working Group, which is a group of myeloma experts, have now defined high risk. So it's really like it's gone beyond sort of this international staging system to now really focus in on genetics. And so there are three, I think, large buckets. One is mutations in this one gene called P53. So if you have a deletion that we can see by FISH, or you have a mutation, that defines one of the categories. If you have one of these joining and rejoining events that produces these translocations, those are high risk, have always been considered high risk, but here they're only high risk if they happen along with some change in chromosome 1. You have to have that to now be in this highest risk category. Chromosome 1 is important because you can either have gains or losses here that put you in high risk. And then the last one is something having to do with tumor burden. So if you have a lot of myeloma, then that puts you at a higher risk. And so this sort of deals with that. So these are the new categories. And what this does is it ends up being about 20% of patients as they get newly diagnosed will fit into one of these categories. So I think that this is used in research to sort of identify these patients, and then we put them on specific trials to deal with and try to understand high-risk disease. So how do we use all this information to go and like actually come up with a treatment plan? So one is that we do this risk assessment, right? But then the other super important part is we think about, are people quote unquote eligible or can they tolerate a high dose therapy and a transplant? So that are things that are based not on the myeloma, they're more based upon things like how old are you? Like what kind of shape are you in? What other organ, what's your organ function? What are things like that are going on? And it includes, I think importantly, what is your preference, right? Like how do you want to approach the disease? So if we take risk and we say there's high and then there's low, in general, what we say is if you're at high risk and you're eligible for a transplant, then we'll go through 4 drugs to start out with. You'll do a transplant, and then you'll do maintenance. And it could be with 2 or 3 drugs. If you're at low risk and you're eligible for transplant, we maybe do not as many drugs. You do a transplant, and then maybe we do not as much as maintenance, right? And if you're ineligible, we'll treat you with drugs. It may differ by number, and then we'll think about going on with just those drugs, or maybe we switch to maintenance. So it's an approach that doesn't just consider these risk categories, but it also considers the patient themselves, right? So that's sort of a standard approach to how we start out with patients, and we sort of say, look, this is where your risk is. This is sort of what we think about transplant-wise, and so you develop a plan based upon that. So the one other thing is, relying on these chromosomal changes is FISH is the primary thing we do, but you got to remember that, chromosomes by themselves, each chromosome contains a lot of genes, and it's those genes that get messed up that cause cancer in the first place. So each chromosome contains like 500 to 3,000 genes, and many different genes are found to be mutated in myeloma, but there's no specific gene that is at every myeloma patient will have, so it's variable, right? So if we think about the genes themselves, like one question is if you have a mutation and that thing is the thing that's causing myeloma, can you attack that thing, right, to try and reduce myeloma? So there's one example that's out there which everybody uses in terms of like these targeted therapies, which is chronic myeloid leukemia or CML. There's a bunch of drugs available, but the first one was a drug called imatinib, and that's been available for the last quarter century. It targets BCR-ABL, which is a mutation that you find in every single patient with actual CML, and it inhibits that specific mutation. And so with that drug, the average survival of patients has improved from 6 years back in the 2000s or 90s to now over 14 years. And in many sort of series, it seems like if you give people imatinib, their lifespan is actually the same as if they didn't have CML. So it's really a game changer in that way. So what about myeloma? So we know that there are sort of recurrent mutations here. And can we match up what the genetics are with a specific therapy? So one of the therapies that people have thought about a lot is venetoclax. It inhibits a protein called BCL2. And what was identified is that there are a subset of patients with this one translocation 1114 that seem to respond better. So if you have, this mutation, then, and you get the drug, this is sort of your progression-free survival versus if you don't. So patients who have it seem to respond much better. There are other things people have tried. So there are these other mutations. There are no drugs that have been yet approved. So we don't have like the magic bullet that we want, but this is something that we've all been interested for a long, long time. Can we come up with a drug for a specific mutation? So, you know, over the last couple of years, the biggest thing I think that has changed things is this idea of minimal residual disease. So this is the idea that instead of like sort of saying to someone at the start, well, these are your chromosomal abnormalities, this is what your risk is, and so this is what we should do. One question is so if we have all these drugs and we give someone drugs, can we monitor them and say, look, these are working or these are not working, right? So can we assess their risk over time rather than just saying it's all up front before they get treatment? So one of the ways to do it is through minimal residual disease. What that means is that, you know, normally we think about patients partially responding or having a complete response. This is based upon things like their M spike, their light chains. If those go back to normal or go away, then that is a complete remission. But you can still have myeloma around, and so can you detect the disease beyond those blood tests, right, which is minimal residual disease. And so if you think about how much myeloma is in a person, like let's say in general, if you hit a complete response, you're about here, but maybe we can, if we can detect down here, then that might give you more clues as to what is happening. So this is minimal residual disease testing. So the way we do it is primarily through bone marrow testing. So you get bone marrow and you either look by a couple of different tests. One is by a genetic test where you do sequencing, or by another test called geometry. We can do imaging, primarily PET scans, and then now development of some blood-based things, but these are not yet approved. So if you look in general at MRD, if you're MRD negative, if we don't detect it down at that low level, it's always better than if we do detect it, okay? So you can see that in newly diagnosed patients who are transplant eligible, these patients do better if they're MRD negative than if they're MRD positive. In ineligible patients, it's the same. And if you have relapse disease, it's the same. So MRD negative is always better than MRD positive after you get a certain therapy. So how do we use this to actually make decisions? And so this is something where we're just coming to the age of figuring this out. So this is a trial that was just published earlier this year, something called the MIDAS trial, where they took patients who were newly diagnosed, they gave them these 4 drugs, they tested for MRD, and then if you were MRD negative, you went into one sort of group, and if you're MRD positive, you went into another. So it ended up being, out of this group, about a third of patients were MRD positive, about 2/3 were MRD negative. If you were MRD negative, you got more chemotherapy, or you got a transplant, and then you went on to maintenance. If you're MRD positive, you either got 1 transplant or you got 2 transplants, and then you went on to maintenance, okay? So here, it was interesting because if you're MRD negative before maintenance, so that means at this point in time, that if you went and just got more chemotherapy, or you went and got a transplant and then a few rounds of chemotherapy, you had the same MRD at the end, right? So a transplant here did not make you more MRD negative, right? So it's an important thing because it suggests that doing a if you're MRD negative, doing a transplant or getting more chemotherapy are actually the same thing as far as this endpoint. Here again, if you look at this group, they ended up, if you had 2 transplants versus 1 transplant, here again, it didn't really matter, right? So doing more if you're MRD positive may not be the right thing to do. The one issue with this trial is that the endpoint, what they're measuring here, is what percentage of patients are MRD negative, right? So it's not how long do patients go before they relapse. It's not how long do they live overall. That's data we need to wait for. But I think it suggests that maybe if you're MRD negative, you don't need to do as much therapy, right? And if you're MRD positive, does doing more therapy actually matter? So right now, what we're thinking about is that how do we use MRD in ways that will be clinically helpful? So the first is we think that if you're MRD negative, that we don't have to do as much. So there's questions now about if you're, let's say, go through a transplant, you're on maintenance therapy, you're MRD negative, let's say for a certain amount of time, can we stop your maintenance? And you'll be okay, right? So that would be an example. So one question is like, should we try to get people MRD negative if they're MRD positive? Is MRD negativity the goal, right? And so should we give patients much, much more therapy if they're MRD positive than MRD negative? But in the MIDAS trial, it suggests that if you have 2 transplants, it's no better than doing 1 transplant. So maybe escalating might be helpful or not. I think that remains to be seen. What is the best test to use? Like, there's no one here. Like, I think, there's bone marrow testing, there's emerging blood testing. I think I've never heard a patient say, oh yeah, can I get a bone marrow now? Like, nobody is ever gonna say that. But to do MRD testing, like in the MIDAS trial, it has to be done through bone marrow, right? So that means you can't do it every month, because no one is crazy enough to get a bone marrow every month. So I think the development of blood tests will allow us to look at MRD over time, right, where you get it on more than one occasion, see how that changes, and that could help us make decisions. And then the other is that how low do we need to detect, right? What is the threshold? And it may be, right now people think about if there's 1 myeloma cell in 100,000 normal cells, 1 cell in 1 million, that's a different threshold. So what's the right threshold? How often should we test? How should we combine it with other tests? Should we think about combining it with like light chains, all these other things, right? And then the one thing that, we've been interested in our lab is really, are the tumor cells in MRD negative patients, MRD negative patients still relapse, or are they any different? And so this is what we have been studying for a number of years. So the last thing is really like, okay, so this is a lot of this is really upfront. So we assess your risk up front, we sort of decide, talk about a transplant, doing that. So the decision-making, I think, gets way more complex when you relapse, right? Because what you have to think about now is not just like, the thing about newly diagnosed patients is none of them have been treated yet before. But if you relapse, now you have to think about, what did you get before? What were the drugs? How well did they work? What side effects did you get from those drugs? How long did that effect last? We have to think about other sort of health issues, like, what kind of shape are you in now? So let's say you get a drug that causes neuropathy. Well, we don't want to give another drug that causes neuropathy, right? So I think it's thinking about what things are in play. I think that we use data from clinical trials. I think if you're relapsing at a slow rate versus rapidly relapsing, it might influence our decisions. Are there new mutations that we see if we go back in and test that are going to affect things? And then I think it comes down to things like preference and what your goals are, right? And so I think that some people will say, look, I want to be as aggressive as I can about my disease, and so I need to do all of these things, right? Other people say, look, I want to, want as little therapy as possible because I want to do all of these things. I don't want to be burdened with therapy. And so these are things that, those are like what I would say the right answers, right? Like the answer that is the right one is the right one for you. So how do we sort of think about this? So I think about this process called shared decision-making. So it's basically like, my job is to sort of educate you about like what is out there, what does each thing do, what are its effects, et cetera, like that. And then your job is to tell me, well, what do you want? Like, what are the things that are important to you, right? And if you, and it's not helpful if people say, and you know, I have 2 kids, and I'll ask them something, and it'll either be like, well, what's important to you? Everything. And it's like, okay, well, that's not that helpful. Okay, well, then nothing. And so you can't have either way. There are things in the middle, and that stuff in the middle is really helpful in guiding what we can do and how we can provide advice. So this really two-way interaction, I think, allows us to build the right plan for you, because my job is to take care of you, right? So what is the best one for you? And then I think that the other things to keep in mind are like your values and your preferences can change over time, right? What you tell me on day one, it may not be 10 years later, you're gonna tell me the same thing, right? So that's something that happens. There are a lot of good options. Sometimes we just don't know, and we just sort of say, well, makes the most sense to me, or feels right. I think that counts for a lot. And then the more I think I get to the opportunity to work with a patient, I think I understand them a little bit better, and I think it makes it easier to sort of make these decisions along the way. So really, in conclusion, there are many different myelomas. We want to assess risk, especially at diagnosis. There are all these factors we have to consider. The risk, remember, is not like what is going to happen to you. It's like the chance of something happening to you, right? So we want to, with that, you know, you got to define sort of how do you want to approach the disease? What are your goals? We want to use risk to help identify patients for trials, especially high-risk patients. And then it's really difficult to assess risk at relapse, right? They're more useful up front. There are a lot of ongoing studies to develop sort of these magic bullet type drugs. Minimal residual disease testing, I think, is a way to help people over time. And then I think that the most important thing is work with the person that you see, right? Their job is to help you. And so you need to sort of explain to them, help them understand how they can help you the best. So I think that's the major thing I would say. And that is it.